All right, I think we'll kick off. Welcome everyone to this month's ISIG meeting. And I'm delighted that we've got Cate Dingelstad going to be presenting to us today. First of all, I'd like to do an acknowledgement to country. For some reason, my screen's gone blank. Can anyone see the acknowledgement to country? No. Let me just see. I'm not sure what's happened there. Is that better if you can see that? All right, so first of all, I'd just like to acknowledge the traditional custodians of the lands on which we meet. And for me, it's the land of the Gadigal people of the Eora Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. And so we pay our respects to elders past, present, and future. And today we've got Cate Dingelstad. So I'm delighted to say that she's agreed to speak to us today. Cate works as a strategic initiatives and research lead for the Hunter New England Central Coast Primary Health Network. And she's worked in the Australian healthcare system for over 17 years and across all levels, so primary, secondary, and tertiary. So a wealth of experience and knowledge. And Cate's also undertaking a PhD at the moment, part-time at the University of Newcastle. And her PhD topic is co-production, co-creation and co-design, fostering health and well-being for people in the community within the primary healthcare context using the 3Cs. So Cate's presentation today is going to talk to this and we'll cover how co-approaches have been used in the past in primary healthcare settings, and in particular what their design and implementation has been and whether there has been any sustained impact as a result of this incentive. And I was really delighted when I heard about Cate's topic for this presentation, because for me, co-design, co-creation, co-production is critical to any research we do. But actually understanding the impact that it's actually had, I think, is a critical factor. So I'm really interested to hear what Cate's going to be talking to us about today. So over to you, Cate.
Thanks, Andrea, and thank you all so much for having me today. I'll just share my screen. You can see my screen, can you? Yep, great. So thank you again, Andrea, for that lovely welcome, and thank you for having me. I'm very pleased to be here and very flattered to be invited. So yes, I'm here to talk to you today about my PhD research, which is titled The 3Cs, Fostering Health and Wellbeing for People in the Community within Primary Healthcare specifically. I'd like to add my acknowledgement to the traditional custodians of the land on which we meet today and their ongoing connection to land, wind and water, where we all live, learn and work. I'm presenting from Wanneroo lands today, which is just northwest of Newcastle, which is Awabakal or Warramai as well. And I'd like to pay my respects to elders past, present and emerging, and any First Nations people with us today. You'll notice that I have 4 different First Nations lands listed on my slide here. Wanneroo is where I live and work, as I mentioned, just north of Newcastle. Anyone land is up near Armidale, and one of the case studies that I'm going to be explaining today will be based up in Armidale. Awabakal is where my PHN office is that I attend, and also the location of another case study, and Darkinjung is the Central Coast, which is the 3rd case study location. So just paying my respects to all of those lands. So what I'm going to talk about today is where I've got up to, essentially, with my PhD research. So I'll give you an overview of definitions and key terms, because they are vast and varied, as you would all know. Talk about the background and the evidence, the why, what the research hypothesis is, the aims, the methods, significance, and then acknowledgements. So starting off with some definitions. As I'm sure you're all very aware of, these words have a vast number of different meanings attached to them. The definitions that have been used within this research have been come to via much reading and a lot of discussion, pulling out the main themes that have come from the literature and the evidence. So as depicted by that circle, co-production is an umbrella term, and it essentially includes the active elements of any co-approach that you might use. So a co-approach is just any kind of approach where you're working collaboratively to improve outcomes. Co-production covers all of those. You might be co-creating, co-designing, co-delivering, co-developing, any kind of co. So it's an approach where all key stakeholders work together to create something new. Co-creation is an active undertaking of a co-approach. So this is the whole project life cycle from beginning to end. So thinking about what the problem is, so the problem identification, and then solution generation through to implementation and evaluation. It is everyone all in, all across the whole project life cycle. So all stakeholders are involved and everyone's input is valued equally. Co-design is less broad and it is essentially just aligned with solution development. So it's bringing all the stakeholders into the room to discuss and figure out what the solution might be for a set problem that's already established. So I wanted to just give 3 examples from the literature around past benefits of use of the 3 Cs. Where the outcome has been really positive. So we've got the first one from Canada. So this is all about access to primary healthcare, and it was about co-designing using root cause analysis, experience-based design methodology, and the model for improvement. The impact of this study was awareness of after-hours clinics and after-hours phone services in primary healthcare increased significantly, and this is one of the only studies in the included studies where they followed up a significant number of years later to ascertain impact. And that was 3 years later, and they found that the incentive had been sustained over that time, which was fantastic. The second one was an Australian incentive in navigation intervention, so developing a navigation option for culturally and linguistically diverse communities in general practice in Australia. So it was co-designed using the Double Diamond framework and experience-based co-design. So the impact of this study was that a bilingual community navigator role was proposed with the proviso that that person or persons were supported with training, supervision, and a clearly defined role description to support those communities within general practice environments. And that assisted with navigating our very complex health system. And then the third one is a US based study around designing and evaluating a pre-diabetes shared decision aid. This was a co-creation piece of work where they used the model for improvement in collaboration with end users. And the impact of that tool was that it was feasible for everyone involved, so clinicians, patients, carers, everyone, and it didn't add time to the clinical consult. So that's just 3 examples of studies where use of a co-approach has been extremely successful. So as we all know, co-approaches that include multiple stakeholders is very much of interest to policymakers and organisations. The theory and available evidence shows that when stakeholders are included early, they have shared ownership of the implementation, which then encourages feasibility and ongoing sustainability. So moving on with my definitions. Defining primary healthcare, it's essentially primary healthcare is what people go to first when they're unwell, so general practitioners, pharmacies, allied health. I've listed the WHO definition of primary healthcare there, which is that it's a whole of society approach. It has 3 significant components. The first is integrated healthcare services. The second is looking at policy and action impacting on the broader determinants of health. And the third is enabling people and empowering people to manage their own health. So that's the definition that's being used in this research. I've got a couple of key terms here, and then we'll move on into the guts of what we've done so far. So the intervention, I've used the word intervention, that could be activity or initiative. That refers to the change being introduced within the primary healthcare context. I've just used a little example here. This isn't something associated with the PhD, but an example of an intervention could be SMS reminders of upcoming GP appointments, for example. Design is the development of the intervention. So the context, the tone, the length and the readability of the SMS message. Implementation refers to the delivery of the intervention, so how it's been modified to suit the local need. So how the SMSs are delivered, what platform's being used, who it's going to, what it's saying, when the SMS is triggered. And the last, no, not the last, second to last, the impact is the demonstration of value to the community and to the system. For example, does the SMS reminder increase patient satisfaction levels and decrease missed appointments? And then finally, sustainability. So as I'm sure, again, you're all aware, this is used very differently within the literature, this word. So the definition that's being used in this PhD is that it's about continued capacity, continued delivery, and continued receipt of benefit from the incentive. So an example associated with that SMS little example there is the extent to which SMSs are consistently sent over time. So moving on to the background and evidence, there are many, many approaches, wildly varied, to the design and implementation. It's been a very, very difficult evidence review because there's so many pieces of literature that use these words and use them differently. There's also a wide variation of settings and study types, and there's no consistency, pretty much no consistency around approach or definitions. A lot of people don't even define what they mean when they talk about a co-approach within the research. So these are some terms that have been cited in the literature in regard to 3Cs implementation. This is just a limited list, so this is not all of them, but just some of the examples. Accelerated experience-based co-design, evidence-based design methodology, experience-based design methodology, root cause analysis, shared decision aids, collaborative service models, participatory design and action research techniques. So it's just a snapshot of some of the terms, some of the frameworks: co-design framework, design innovation, patient engagement, double diamond, and so on. So that's, again, not all of them, just a snapshot. And then some of the tools, just broad high-level tools cited: questionnaires, the model for improvement, ladder for citizen participation, checklists, design thinking, and then 3C support tools, so tools that are specific to 3Cs implementation that are separate to the previous slide. We've got quite a number here around guides. So 2 guides named the same thing, developed by 2 different centres. Experience-based co-design toolkits, All of Us guide and toolkit, which is quite a recent one. Co-design Kickstarter, co-design kit, methodologies, yada, yada, yada. There's so many out there that are really good tools and really worthwhile. All of these have really great components to them. The point I'm trying to make here is that there are currently no overarching 3C support tools directly specific to our Australian primary healthcare context. So whilst all of these tools are relevant and can be adapted, there's nothing specific. So why is this different? Why is this work different? There's been so much research done within the 3Cs, or within co-design, within co-creation, co-production. They are potential keys to improving outcomes, supporting health promotion, health equity in the primary healthcare sector specifically, but we have a big gap within our research knowledge on impact and sustainability at the moment. So that's what this knowledge gap, that's what this PhD is seeking to address, looking specifically at primary healthcare. So the purpose is to understand how to best implement this kind of approach effectively, sustainably, with the best impact. And what we hope to do is create recommendations to inform the development of some implementation guidelines to support the use of 3Cs in policy and practice, which will impact then on community outcomes. So that's the hypothesis. In primary healthcare settings, effective use of a co-approach can improve health outcomes for individuals and populations, clinician retention, and also value-based healthcare. So the research aims to look at how the 3Cs have been designed and implemented to improve health and wellbeing outcomes for communities, to evaluate those those designs and implementations to see whether there's been impact and sustainability, and then to provide recommendations around localisable guidelines within primary healthcare specifically. There are 3 components to the methodology. So the systematic review, which we are just at the end of at the moment, looking at those 4 factors. Doing a case study analysis, I mentioned right at the beginning that we'll be looking at 3 different case studies. I'll go into those in a little bit and explain what they are. And then conclusions and recommendations for that implementation guidance. Okay, so I'll just drill down into those 3 things briefly and give you an overview of where we're up to. And then there'll be quite a bit of time, I think, for some questions. So the systematic review, we used 2 frameworks to inform the literature searches. There's been 2 searches, just given the amount of time between the 2. So we used a modified PICO framework for qualitative research and the SPICE framework. We looked at 3 databases and put the following limits there. We found just over 1,000 articles, and 30 of those were accepted for inclusion. So the preliminary key findings over those 30 articles is that the definitions used are wildly varied. We have a range of settings and approaches that have been used, and there's very little detailed information around the impact of the approach or the outcomes and how it's been sustained. So it's been an interesting journey so far. The results from the systematic review will be delivered as a modified logic model using something called the FATE framework, which I'll talk about in just a minute. And that will be developed detailing the outcomes of the review. So this is the FATE framework. It was actually developed by the Hunter Medical Research Institute in 2022. So it's a combination of 3 different methodologies for measuring research impact. The first is modified payback, which is knowledge, health services, political and policy impacts. The second is economic analysis, so return on investment. And the third is narratives, so the qualitative impacts. So this approach allows for triangulation of methods, which is sometimes challenging in qualitative research. It just covers the normal things that are covered by a logic model, so the demand addressed by the research, what the aims are, what activities are being developed and put into place to address the demand, and what the outputs are expected to be. And those 4 things are co-created with stakeholders and end users. Then the end users are obviously those who use the outputs, who the end users are, and then the intermediate and the final impacts, what we expect those impacts to be. So in terms of outcomes at this stage, we're looking at significant variation in context of application and approach. There's a lack of consistency in understanding and adaptation of any of the 3Cs approaches. There's a lack of evaluation data to understand the value of the approach or support the effective design and implementation of any future approach. There are some common implementation challenges that are emerging, and something that we have found is that if 3Cs approaches are becoming increasingly used, which is the case, this review will demonstrate the gaps in our knowledge in relation to the framework use, design, implementation guidance, and evaluation. Did I want to? No. Okay, so case study analysis. We're just progressing on this one now. So again, we'll use the FATE framework for each of the 3 case studies and develop one logic model for each case study to summarise what we found in each area. They will be, the first one is based in Newcastle, New South Wales. So it's a metropolitan setting. It's an early years education and social integration intervention. So it's looking at between 0 to school age, essentially, when kids go to school, and how that can be, how the support of those people can be streamlined across multiple different settings, including police, education, health, community services, etc. Second one is a neighbourhood-driven approach supporting older people on the Central Coast, so at the opposite end of the spectrum. So we're going from young kids to our older population. This one is about how we put in place a neighbourhood-driven support network for people to stay in their own homes and gain care that they need. And the third is a model of care for chronic pain management in Australia, in Armidale, I beg your pardon. So we have basically a metropolitan approach, a regional approach on the Central Coast, and then a rural approach in Armidale. We'll look at the study, we'll look at documents, we'll look at observation of meetings, we'll look at interviewing and surveying, and focus groups and workshops to collect data. I'll use grounded theory to analyse and theme from all of those three contexts as well. And as I mentioned, we'll develop a logic model for each of the three case studies, and we'll have the logic model from the literature review as well. So we've got 4 different logic models that we'll then assess and synthesize at the end to create those recommendations for guidelines. Just a little comment around bias here. So obviously, to manage bias, we're going to be using a reflexive dialogue sessions as we go throughout the process to discuss possible biases that might influence the interpretation of the data. So those will be regular meetings just to check in and ensure that bias isn't being included. Yeah. Then the conclusions and recommendations, synthesis of all evidence, including the systematic review, will be those logic models. Those will underpin the development of recommendations to inform the implementation guidelines. It will also include limitations, of course, experience to date, and give an overview of the next steps, and highlight any opportunity found for translation. So what? Who cares? Well, it does add value. It will provide an assessment of impact and sustainability when using the 3Cs. It will provide those recommendations around how to best sustain any positive impact from a 3Cs approach. And it will probably be, well, I'm hoping it will add to the knowledge that we already have around how to design and implement 3Cs approaches. Again, a reminder of the hypothesis. And then just acknowledgements. So Nick Goodwin is actually here today. He is my primary supervisor. He's Director of Research at Central Coast LHD and Director of the Central Coast Research Institute as well. Nikki Hoddle is a supervisor as well. She's Chief of Research Translation and Healthcare Improvement at the Hunter Medical Research Institute. Rebecca Wise, who is a Research Fellow at the University of Newcastle. Suzanne Lewis has contributed heavily to my systematic review. She's the Chief Knowledge Officer at the Central Coast Research Institute. And Dr. Alison Koshel is my Executive Manager at my workplace, Primary Health Network. So just acknowledging the work and support of all of these amazing people as well as I progress through this rather sticky and tricky space. And that's it from me. Any questions?
Thank you, Kate. That was fantastic. And all I can say, that's an ambitious piece of work that you're undertaking. I can see, I mean, even starting from the systematic review, the challenges you've had, even in just establishing definitions around terms that are probably used very broadly and, as you say, often not defined. And delighted to see that you're going on to use grounded theory for your analysis. That's what I used in my PhD, which I think will be absolutely perfect for this research question. I mean, I might just start off with asking you around the systematic review. I mean, were you surprised to find so little consensus around definitions of, you know, co-design, co-production, or did you enter into this fully expecting there to be that level of ambiguity?
I didn't expect the level of ambiguity that I found, I have to say, and I was a bit astonished that we've progressed so far with such a fantastic methodology without actually understanding exactly what we mean by it. And that's not just Australia, that's internationally as well. So while there's an argument for this just being semantics, there is also benefit in being really clear about what we need. what we mean when we're talking about each of these approaches. So, yeah, I think it's important to understand the definitions.
Yes. Well, I mean, for me, even you just there providing a definition of co-production, co-creation, and co-design was really helpful for me to try and clarify the differences between those terms that I haven't really, I suppose, sat down and thought carefully about what the differences are in them. So that's a fantastic achievement in itself.
Thank you.
Any questions from anyone else? Either pop them in the chat or just put your hand up. I can't see everyone on the screen, but just feel free to take yourself off mute.
Oh,
Steph.
hi. Oh, sorry.
No, go ahead.
Steph, you did better than me. I couldn't find the hand for some reason. I think Zoom's changed. Sorry if I jumped in.
Do you know, they've hidden it in that heart-shaped react button, which it took me some time to find it. But anyway, you go first, and then I've probably got a very dim question, so I'll go after.
Oh, thanks. Cate, congratulations, to get to this stage. And I'm really excited to see how your work progresses. So I'm also doing a PhD in PHNs, and while it's not looking at co-design's a kind of really interesting element of it. What I'm really interested in is measuring impact and how, so I'm looking at it from a learning health systems perspective, which I think there's some interesting resonances. So what I'm kind of looking at is how we actually measure that things have made a difference. And I'm keen to find out what you picked up in your systematic review in terms of, what did people kind of find through this co-design process? Like, did you see emerging that people could recognize through this co-design or co-creation process measurement indicators?
Yeah, great question. Not there yet. So we don't have an example of that just yet because the analysis hasn't been quite completed. But in terms of the different, it's challenging because there are different approaches. So that we've got, 66% are qualitative approaches, 17% are mixed methods. There's quality improvement in there as well. And we've actually included a systematic review in the included articles as well. So in terms of that measurement piece, I don't know the answer at this point, but I can certainly come back to you because I will know in about a month.
Oh, great.
What those are. Yeah, so I'll take that one on notice.
Thanks.
Steph, do you want to jump in there? And I see you've also shared what looks like a really interesting paper in the chat as well.
Paper's probably more interesting than my question, but I thought I'd just share a paper that a colleague of mine, Sanna Peters, has been working on around the evaluation of research co-design. So I thought that might be quite interesting for some of the people on the call. But my question, well, thanks, Cate. Lovely, lovely presentation. And I really enjoyed sort of hearing a lot of that literature coming together, and I can relate to that. Confusion's the wrong word, isn't it? But that sort of that disparity across all of those sort of definitions kind of thing. But my question was going to be around, you've talked about the 3Cs and you're looking at the 3Cs. So would it matter? A lot of the time people don't necessarily do all three. They don't necessarily do co-production and co-creation and co-design. And so the work that you're doing, is it only going to apply to people who apply the 3Cs, or is it for people who do work within one of those Cs? How do you see that working?
Great question. I think that we'll probably approach it from a co-production perspective, which is encompassing any kind of co-approach that you choose to deliver. Obviously, it's going to be an interesting journey because those implementation guidelines are going to need to be quite high level, just in terms of being able to localize any kind of incentive, but there needs to be enough direction in there as well to be able to either apply it to a co-creation process, which is an end-to-end process, or a co-design process, which is much more limited and only the solution development stuff. And then you've got the other co-words like co-delivery, co-development. I'm sure everyone on the call could come up with 1,000 different words that people use for a co-approach. But I think we'll probably just try to approach that from a broad spectrum. This is not specific to any particular co, but it gives you a pathway on how to actually do something successfully with impact and sustainability as the focus.
That sounds great, because then that's got much more use, hasn't it? And so more of us are going to be able to draw on your work. So thanks, Cate.
So.
Is that Karen got a question?
Yes, it's Karen has got the question. Great presentation, Cate. Absolutely, I had no doubt at all that everybody would be very inspired by this. I just wondered, because you're going out to quite diverse populations, your sort of areas, and language can be quite confusing. And how are you going to sort of let people know what you're actually going to be looking at? Just because I know when I speak to different people, we all have this, never-ending conversation about what we're actually meaning. So, I mean, how are you going to sort of, in each of those projects, how are you going to sort of highlight what it is you're trying to do?
Great question, Karen. A challenging one, because what I'm actually doing in those case studies is I'm assessing and evaluating the implementation process. I'm actually not assessing the participants as much. So
Right.
the people where the people that are being impacted by the incentive, so the older people on the Central Coast, the children in Newcastle, or the people with chronic pain up in Armidale, I'm not touching them as much. I'm more looking at how the activity has been undertaken, what the intention was at the beginning, whether that intention has been delivered upon, and whether it's actually going to be sustained. The sustained bit is going to be an interesting one, because these projects are either currently in place and only for the last couple of years, or they're new. So there's not going to be a lot of opportunity to look at sustainability associated with these specific case studies. But what I will be looking for is around whether they are looking to plan for that at the beginning, and what strategies they're putting in place to deliver that sustainability piece as they go along, and in terms of embedding it into the community. So I'm not sure if I've answered the question entirely. Also, ethics is obviously a big part of it. So having communication information sheets, lots of conversations with people who are involved, answering lots of questions. Yeah.
So are they mainly going to be sort of clinicians and researchers, or are you actually going to speak to them?
A lot of these things are community led. So no is the answer to that. We have they are true co-design pieces.
Yes.
The one in Newcastle is co-creation, so it is led by community. So those people are entirely community. A lot of them are service organisations, so they do have some understanding of bureaucracy and how research works, but that one's co-creation. The Central Coast one is a true co-design, and the chronic pain one has yet to start, but that's also a true co-design up there as well.
Okay. Yeah. Thank you, Cate. Thanks.
Can I ask how you managed to get all three of your case studies on board?
Well, that's an interesting question. Through working at the Primary Health Network, and also being involved with, one of them is being led by the Central Coast Research Institute. So that's one of my sponsoring organisations. One of them is solely because I've been asked to attend as a member of the Primary Health Network to input into the community incentive. That's the Newcastle-based one. And then the chronic pain incentive is part of New South Wales Regional Health Partners, of which the Primary Health Network is a member. So that's kind of how they've come about.
Well, I think fantastic diversity of case studies that you've got there. And I can see you're going to end up with a huge amount of data. I mean, do you see any challenges in being able to compare across the case studies in terms of, you know, the outputs and the impact?
I don't think I'll be able to compare them because they're so different. There might be key things that come out of the chronic pain and the older people topics because they're both co-design. But what I'm hoping is that I can pull out the key themes of things that have worked, things that haven't worked so well, and then use those.
Fantastic. Question from Nada.
Hi, congratulations. Well done so far. Good luck.
Thank you. Yeah, thanks.
My question kind of follows on from the conversation you were just having with Cate. Are you going to be looking at kind of what process measures are put in place to assess the potential for sustainability, or do you have an idea of what those process measures might be already?
I don't, because I haven't started the case study analysis yet, but yes, I will be looking for whether they have planned evaluation, number one, at the beginning, and whether they've actually thought about how they're going to measure, because you need KEQs at the beginning, don't you? So, and whether that will have any impact on sustainability as they go through.
Awesome. Awesome.
Yeah.
Look forward to reading more about your work. That's great.
Thank you.
Any other questions from anyone? I was wondering, Nick, if you have any comments on this, given you're Cate supervisor.
Oh yes, many. Look, I think the key comment from me is that these terms get bandied about all of the time, don't they, without any real understanding of what they mean, how to put them together. So from my point of view, being able to implement something like my program, which is part of where Cate will be doing her work, is focusing on a co-design project with the local community to build a neighbourhood model of care for older people. We're probably not doing co-design at all well, but the idea is that we do. So we have residence committees and we have co-design events and so on as we try to build a model from the bottom up. So, but we have been using some guidance, but if we had guidance on how to do that from the beginning, I think it would have been really helpful to understand the sorts of things you need to put in play, but not just the frameworks, but actually the guidance for implementation, where you hold a meeting, how you hold a meeting, you know, getting into the nitty-gritty of what it is that you would really want to be able to do. Plus, on the other side of it, how would you evaluate the effectiveness of your co-design as a result of putting it in place? So we have some feedback mechanisms, but mostly around the sessions that they've received, not necessarily the process of co-design that they've been involved in. So for me, I think it's going to be enlightening to help future approaches to co-design, because everybody's seeking to say, well, let's do co-design with research, let's do co-design with consumers. It comes in every strategic plan without any meaning. So being able to provide guidance to the sector on what it means, how you do it, and how you evaluate it, I think would be a really useful contribution. So supporting Cate over the next couple of years, I think is going to be really good to see how, you know, where this ends up and what we can say. Because if you saw in the presentation, you know, 20, 30 different types of frameworks, 20, 30 different types of tools, making sense of all of that when you're coming into it cold from the health service or from the social care service or from the community can be a bit daunting. So you pick one that you understand, or you make it up as you go along. So having some guidance around how you do things, I think could be useful. And then the next step would be, is it useful? So you can actually test out this guidance to see whether it does support these processes as well. So yeah, I think it's what I like about it's got great utility. It's not just, you know, from an academic point of view, understanding the semantics of the 3Cs, as someone mentioned, and recognizing their importance is key science. We need to understand that. Otherwise, we're just doing things without understanding the benefit of them. But it's also got a great utility for implementation. So the two things together, advancing science, advancing implementation, is exactly what this kind of group you're seeking to do, and what I'm really keen to see happen. So for me, it's great to have Cate involved in a project like this, because it's just, you don't have that information to hand readily. Even if there's a lot, it's like there's so much about, but actually none of it's useful. You know what I mean? You see that all of the time. And somehow finding something that will actually be useful and instructive and supportive, I think, is something that as an end product would be terrific.
Well, I totally agree that, I mean, everyone is under increasing pressure to embrace co-design, and people claim that they're doing it. But I think knowing how well people are doing it, and then also following that through to actually understand the impact it's had in terms of implementation is critical. And I think the slide that Cate showed with all the different 3C support tools, I think it is actually mind-boggling the amount of resources there are, but actually how you find something practical that is useful. It would be really, fantastic if that's the endpoint that you get to. So do you think, I mean, given this is focusing specifically on Australian primary healthcare, do you think there are specific challenges that are unique to that situation? I mean, that's for Nick or Cate to sort of respond to.
Yes. I mean, obviously, our biggest challenge is how our primary healthcare system is funded compared to how our secondary tertiary healthcare systems are funded. So that is our primary challenge that's different to the rest of the world. The closest comparator really is Canada in terms of how they run their health system. So that is a big factor in terms of how things would look different here. The studies that have come out of this, 4 of them, of the 30, 4 of them are Australian and the remainder are international. And all of the international ones have elements that are relevant to our context. But I think it's just about pulling out the things that can be applied here, and given the broad reach of our nation, we have heavily metropolitan areas, we have regional, we have rural, we have remote. We have very remote. So how we actually adapt these guidelines to each of those different contexts as well and make them adaptable is front of mind in terms of how we're going about this. Did you want to add anything, Nick?
No, I agree. I think it's difficult, isn't it? I mean, why would the approach in terms of its principles and characteristics and the guidance you provide be different to anywhere else? And I think one of the things that you can work through is an understanding of what those universal principles are likely to be. How you then implement them within different contexts is a fascinating question, implementation question. I think, as well as the funding, there's a very cultural difference in Australia to the way people operate. The relationship between primary healthcare and the other sectors is different, I think, if you look, but on the other hand, but it's also the same. So you just got to try to tease through, I think, as you do the case studies, thinking through what are the lenses that we're looking at that difference in funding, governance, accountability, provision, culture, professionalism, all sorts of things might come through in the case studies as you begin to look at those relationships. In the end, these are complex relationships. It's a real implementation question to understand how people can actually, how can you do 3Cs effectively is really a relationship question, how you bring people together for a common interest. Mm-hmm. And I think in Australia, I found, without doing research on it, there are several layers that perhaps are a bit more difficult than maybe some other countries. And that's partly because of the nature of the way you have state and commonwealth resources, that you have public-private sector all working together, the very siloed nature in which the Australian health and care system operates, the lack generally of community enablement mechanisms that you see in other countries. So it's a different environment in which we're trying to do something. It doesn't mean it won't work, but it means that there are some specific challenges to Australia. So picking out those specific challenges, what it means for Australia versus the international lessons of what this means for the rest, I think will be very useful, because there'll be lessons in both ways.
Thank you. Any final questions? Anyone else got anything else they'd like to ask?
Hi, I'm sorry. I still haven't worked out how to
Yes.
put my hand up, which is funny. Thanks. I'm just reflecting on what you're describing, Nick, and I'm wondering, Cate, you know, as someone who would be eagerly awaiting, you know, these recommendations and guidelines, I'm just thinking because the contexts in your case study are very different to the context that I'm using co-design in. Is there where will you kind of get a sense of how guidelines would meet the needs of users? I mean, I think that what we're currently doing perhaps is we're being told to do co-design, but no one's being funded to do it. And there's no remuneration for stakeholders. It's really hard to bring about co-design. And so we're probably cobbling together efforts. I know I'm running co-design through education sessions, you know, GPs come to learn, I learn from them. Do you know what I mean? So we kind of probably cobbling a lot together and just trying to do co-design in the spaces where we convene. But then the guidelines would be useful if they could say, well, even if you just got this situation, here's how you could use the co-design approach, you know, that kind of guideline. So
Examples.
yeah, fit for use, fit for purpose. There's very practical things that, you know, you might not have to do it perfectly, but you could do it. What is it? Don't get the perfect get in the way of the good. But yeah. So anyway, I guess my question is, I'm wondering how through this thesis or this inquiry, those recommendations will kind of meet the need of end users of the guidelines.
Again, great question. I was going to try and write implementation guidelines within the PhD, and it became evident quite quickly that there was not enough time for that, taking into account the wealth of information that's out there already. So one would hope that that will be the next step as we go along. In terms of, you know, I'm going to provide recommendations for implementation guidelines, but I would like to see them be created in the long time. In the long term, time frame is a bit of a there's a bit of urgency attached to this because there is a window of opportunity here where we're all asking the same sorts of questions. So this question is being asked across lots of different forums. So I do need to get my skates on and get things sorted and, you know, get it sorted as quickly as I possibly can and get the work done and move forward with it. I don't think I've answered your question, Bianca. Remind me what it was.
No, that's okay. I guess I was just thinking in terms of your study that you'll do the case studies and then you'll create some recommendations about what guidelines, but then there is possibly a next phase, isn't there, that's perhaps interviewing people who are implementing to find out how guidelines would work in practice. But I completely agree. I think that's right. I think this is going to be very exciting, and agreed. I think that you know, it's like not framework paralysis, but at the moment we're greeted with so many tools and so many frameworks, and we're trying to work out what's fit for purpose. And so I think people just go on and do stuff, and it's probably a bit mucky and messy. So I think that, this is going to fit a real need. Yeah.
Extra time and extra money is needed for any co-approach. And I think that's something, that messaging just needs to be, you know, clearer as we go along.
Great. Look forward to seeing how it works. Yeah.
Well, congratulations, Cate. And I think it's clear that you've probably got enough work there, not only for a PhD, but probably for a postdoc as well.
Maybe. Yeah.
So yes. I mean, I wish you every luck with that.
Thank you so much for having me.
No, it's been a pleasure to hear about your work, and you know, we all eagerly await your results. I think it'll be really interesting to hear about your findings. So perhaps you can come back and tell us more later on when you've got more to report. That'd be fantastic. So unless anyone has one last question or so, I think we'll wrap it up. Thank you, everyone.
Well done.
That was fantastic, Cate. Thank you.
Thank you very much. See you later.
Well done.